So we were just talking about the glans penis, combining form Volano, and there is a skin fold, if you will, that covers it. It's called the prepuce, or the foreskin, and this is a fold of skin that covers the tip of the penis. So when the male child is born, there is this covering over the glans penis. It's could be a possible source of some pathologies. It could also be something that gets removed, and that sometimes is an elective surgery. Well, in fact, most cases it's elective. Sometimes it's required. So before we really get into how it's removed for general purposes, we'll get into something a little bit more specific, and that's phimosis. This is a tightening of the foreskin of the penis caused by the inability of it to retract, and this closes the opening of the penis. So it's not the urinary meatus that's blocked, it's the actual prepuce, and it's held together by a frenulum. So a frenulum, you may have noticed before, if you lift your tongue up and look underneath it, you see a vertical piece of tissue that ties the tongue to the floor of the mouth. That's known as a frenulum. The inside of the foreskin of the prepuce has a frenulum that extends to the end. Sometimes it goes all the way to the end of the prepuce, and what it does is it holds the foreskin shut over the end of the glans penis, makes urination very difficult. Once again, urinary meatus is not blocked, but the actual prepudial opening is blocked, and so it doesn't allow for urine to pass through. That could be a reason that to do surgically induced circumcision, which is what we're going to talk about next. And circumcision, although mostly in Western culture, is an elective procedure. Some parents are led to believe that they have to do this before they leave the hospital. They do not. Circumcision, unless there's a pathology, is completely an elective surgery, considered cosmetic surgery, if you will. It's a surgical removal of the foreskin of the penis that's usually performed when the male is an infant. So in Western culture, I would say anywhere from Western Europe through the United States and probably most of North America, this is considered to be practice. And it's just because it's been done for so many years. And once again, there are doctors who will say, oh, no, we have to do this. It's a standard procedure. It is not. It's an elective surgery. I have assisted in circumcisions before. Not my favorite procedure. It's usually challenging. We have to strap the baby down, of course, and they do everything they can to keep them warm and safe and comfortable. Nevertheless, it's usually quite torturous for the child in some degree. Of course, we numb the skin and all of that, but it still causes some problems. So what happens is once we have the child sort of in a position where we can do the work, and often we have to use restraints on the legs and arms because they're going to try to resist. Once the restrained foreskin is lifted using retractors and the glans penis is exposed, a plastic bell clamp is placed over the glans penis, and usually a wire or something else is attached behind it that kind of cuts off the blood flow. Within a few days, that foreskin will then fall off, the bell cap will remain, and then that bell cap is removed and the procedure is complete. Its origins are in the Jewish religion, and it was done, I'm guessing, for hygiene reasons, although I honestly don't know. There's all stories about how this was used during biblical times to identify people by their religion and so on and so forth. Very controversial practice in ancient times, still occurs today. In the Jewish religion, they do believe in circumcision as a religious rite. In Western culture, we accept that. As I said, we also accept it as a medical procedure. So here on the right, you see a before. Then after the prepuce or the foreskin is gone, we see the normal healing, and then the after presentation. So that itself is circumcision. Do note that circum, meaning around, is part of the word. So hopefully that'll help you think about it. And if you think incision around, although the whole word incision's not here, circumcision sort of sounds like it. So if you think it's an incision around something, it might help you to remember that. Big part of male health is the prostate gland, and it's a combining form is prostata. It's the gland surrounding the bladder. It does not surround the bladder, it surrounds the urethra, so that's an incorrect statement. It controls the release of urine from the bladder and secretes fluid that makes up part of the semen. So you see where its location is right here, and I've mentioned in a few other slides, so you'd be ready for this slide, that you see that the urethra comes out of the bladder and goes straight through the prostate. and you see that passage, there's another canal coming behind that connects with it. That's the vas deferens. And that all comes together at the same place that we have the Bartholin glands, which, or the Cowper glands, pardon me, which are going to help produce also fluid for semen. So notice location, and very important to understand that, because when we start talking about the pathology that's associated with the prostate, its location and the structures that go through it will be relevant to that discussion. If there's any suspected pathology of the prostate and as a regular men's health routine check, it used to be standard of care to do the digital rectal exam, a screening test that examines the prostate gland by finger palpation. Data over the years has proved that the DRE is not the most effective way to check and see if a prostate has enlargement or any pathology associated with it. So it's not done nearly as much as it used to be. Many times they look at the prostate via CT or MRI or another form. However, DRE is still relevant. It's performed for more than just prostate. In this case, a finger, is inserted into the rectum, palpated through the intestinal wall, and you can see in the depiction, that's not a normal looking prostate. And so it depends on the texture of it is how the urologist will determine if it's potentially a problem or not. And there within is the problem, because sometimes the texture is misinterpreted. And once again, not exactly standard of care anymore, but it's still used. So some of our terms associated with prostata is prostatic, pertaining to the prostate gland; prostatomegaly, which is enlargement of the prostate gland; prostatitis is inflammation of the prostate gland; and prostatectomy is excision of the prostate gland. So we have a couple of different things that might cause enlargement, so the megaly, or inflammation of the prostate. And this is generally true in medicine, but not always, and definitely true in the prostate, that megaly and so enlargement and inflammation are kind of going hand in hand. In this particular type of pathology, that is true. So if we take prostato and combine it with cysto, and once again, urinary bladder, because we talked about this last week, and we have more than one bladder. In this case, we are talking about the urinary bladder because of the close association between prostate and urinary bladder. Prostatocystitis is inflammation of the prostate and the bladder together. So there's some reason, probably bacterial infection, that is causing this inflammation. Of course, it's going to have an effect on the urethra and the ability to urinate. And we also have prostatocystotomy, incision of the prostate and bladder. So that might be a way to deal with prostatocystitis and get that urethra open, although it wouldn't be the most common way to do it. When I talked about the enlarged prostate having a texture, you can see the difference here, and this is depicted quite well. The normal prostate is generally will have small, rough ridges that kind of feels like your Adam's apple in your neck, that sort of cartilage that covers the Adam's apple, or that covers the thyroid, rather. If you palpate your neck or you palpate your trachea, that kind of texture is what you would expect. Large, smooth lines like you see in the enlarged prostate. During a DRE, that might be interpreted as a reason to do a biopsy, but biopsies often lead to complications and don't always solve the problem for the patient. Hence, DRE is not standard of care anymore. Getting back to our slide though, prostatocystitis or prostatocystotomy, these are the words associated with the combination of prostato and cysto. And of course, as I've said before, just about any organ in your body can throw stones, as well as the prostate. So once again, with our combining form prostato for prostate gland, we have prostatolith, a stone of the prostate, which is very small, as you can see in the comparison here. Comparative analysis between the stone itself and the size of a dime. Very small, however, very much troublesome. And we also have prostatolithotomy. This is an incision of the prostate to remove a stone. And so surgical procedure to get that stone out of the way, not an area of the body where they're likely to do something like the extracorporeal lithotripsy that we talked about in the urinary tract chapter, where it's high wave ultrasound. Not likely to happen there, although it could. Depends on the doctor and the surgeon and the patient and the pathology. Okay, so we're going to walk you up to a pathology now. I'm going to take you through some words so that when we get to the pathology, it'll make sense. We're going to use the suffix trophy for growth or nutrition. So this word looks like hypertrophy, and it is not pronounced hypertrophy, it's hypertrophy. And it's the same hypertrophy we discussed with the heart, especially with the left ventricle. Left ventricular hypertrophy is very commonly seen in athletes. It just means they've worked out a lot and really developed that left ventricle muscle. In this case, though, we're leading towards a different pathology. Hypertrophy in this case is enlargement or overgrowth of an organ or body part. So kind of describes the same thing, but different part of the body. So trophy is part of or hypertrophy rather, is part of our diagnosis we're working up to. And then we have something called plasia, which means development or formation. So if we put A on there, which means little or none, it's a lack of development of an organ or body part. We use dysplasia, and dysplasia is our word of focus here. It's the abnormal formation or organ of an organ or body part. So aplasia, there is no development. Dysplasia, there is development, but it's abnormal. We have baby hips, so hip dysplasia that we're illustrating here. This is a very common form of dysplasia in babies. When I say common, I don't mean like, 1 in 10, but we see it often enough. And there are different methods. There's a Pavlik harness that you see here, or the short hip leg spica, which is more or less a cast. If the hips are not aligned, and we do this with ultrasound in radiology, we do not radiate babies for this. But we're using ultrasound. If there's evidence of hip dysplasia, it would indicate abnormal development of the hips, so we want to correct it. But our takeaway word here is dysplasia. So that's really what we want to focus on, abnormal formation of an organ or body part. So along with the others, and this is the one we really want to focus on, is hyperplasia. So once again, we have plasia. We're putting hyper in front of it, meaning abnormal increase in the number of cells of an organ or tissue, which results in enlargement. So once again, our diagram here, we have a normal prostate, which is just kind of doing its thing. It has the urethra passing through, the vas deferens coming from the posterior to the anterior and intersecting with it inside the prostate. And then we have the enlarged prostate in the next picture. It looks like the urethra is completely blocked. The vas deferens also doesn't really have a clear path. And we also see that we have urine backing up in that urinary bladder. Not to mention that it's pushing that urinary bladder up, so it's kind of causing a form of prolapse. The bladder is not sinking, but the prostate is rising, and it's causing those little pockets that can trap urine, much like we talked about when we talked about cystoptosis. So that's what's going on here. That prostate, it has those vessels going through it. It's enlarging, it's pinching them off. And the pathology I've been leading you up to is benign prostatic hyperplasia, BPH. Gentlemen, for all of you, if you live long enough, you will have some form of BPH. Usually symptoms start as early as the 40s. By the 60s, if you haven't had symptoms, you're likely to have them. This is a gradual enlargement of the prostate gland. It's a normal occurrence as we age. It leads to a weak urine stream. It causes the inability to empty the bladder completely. So increased urinary tract infections in males and inability to start a urine stream and frequent urination, polyuria. And the reason for that is when urination occurs, the bladder isn't completely voided. Although it feels like it's empty, it's not. And suddenly a few minutes later, the urge to urinate comes again. That all has to do with the fact that this prostate is enlarged, pinching off these vessels and making the flow not so easy. It doesn't flow well. So once again, gentlemen, if you live long enough, you will see signs of BPH. It's just part of getting older. It's that badge of honor that we've lived long enough to earn this pathology. So we're going to give you a new word here, and it's going to lead to one of the things that they do to relieve the symptoms of BPH. We're going to use trans, meaning across or through, and we're going to attach it to urethra, you'll recall from last week, and we'll give it a pertaining to suffix. We have transurethral, literally means pertaining to through the urethra, and there we also see that scope that we talked about. And in the male, we're using the static scope in this particular situation. Static meaning made from steel, so it's rigid, it's non-flexible, and we're using that to help facilitate a TURP, transurethral resection of the prostate, surgical procedure that relieves obstruction that's secondary to BPH. A resectoscope is inserted through the urethra, and it trims away the excess prostate tissue blocking the flow. So this can also be done for mild forms of prostate cancer. If anuria or oliguria is occurring as a result of inflammation of the prostate on the urethra, this procedure can remove some of that tissue and allow the urethra to once again flow more freely, and thereby reducing that symptom and the discomfort of the disorder. And I have just about 5 slides left. We're going to have to do it in another segment because I'm out of time. So I'll be back with you in just one moment.